Good afternoon, ladies and gentlemen. It's my pleasure to welcome you to this hotline session fully dedicated to hypertension. It's also my pleasure to announce that during an ESC Congress meeting, this is the first time that we have a hotline session fully dedicated to hypertension. My name is Genevieve DERUMEAUX. I am coming from France, Paris University, and it's my pleasure to co-chair this session with Professor Issei KOMURO coming from Japan, Tokyo University. So we'll have 4 interesting new trials being presented and being discussed. I would like to ask you not to take any picture, and I do thank you for taking into account this recommendation.
Okay, thank you, Genevieve. It's a great pleasure for introduce the first speaker, Dr. Hisao Ogawa from Kumamoto University, Japan. The title of his talk is A Trial of Telmisartan Prevention of Cardiovascular Diseases, Attempt CVD, the large biomarker study with 1,228 patients. Dr. Ogawa, please.
Okay. Thank you for Professor DERUMEAUX and KOMURO. Good afternoon, everyone. I would like to thank you for giving me this opportunity to present our work. This afternoon, I will present the result of the Attempt CVD. This study was a comparative study to examine the effect of angiotensin II receptor blocker ARB therapy and those of non-ARB standard therapy on both the biomarkers and the incidence of cardiovascular events in hypertensive patients. This is COI. Here is the background. Angiotensin II receptor blockers ARB affect the levels of such biomarkers as urinary albumin and plasma brain natriuretic peptide, BNP. There are many reports that microalbuminuria is a risk factor for cardiovascular events, all-cause death, and hospitalization for congestive heart failure. Elevated plasma BNP levels can also predict of death and cardiovascular events. There are few studies that measure these biomarkers continuously over a year and investigated cardiovascular events. For these needs, we decided to conduct this comparative study to examine the effect of ARB therapy, telmisartan, and those of non-ARB standard therapy on the biomarker level changes and the incidence of cardiovascular events in hypertensive patients. In this multi-center prospective randomized open-label active controlled trial with blinded endpoint assessment, patients from 168 institutions throughout Japan were enrolled. Eligibility criteria were age 40 to 80 years, hypertension, and at least one cardiovascular risk. The approximate time for patient enrollment was 2 months from 2 weeks before the start of the study. As a patient's visit to the outpatient clinic, blood pressure was measured in the sitting position, and for those who didn't achieve the target blood pressure, the drug doses were increased. The study protocol was in agreement with ethics committee. At study registration and after 3, 6, 12, 24, and 36 months, physicians examined the survey items including drug compliance, concomitant drugs, concurrent therapies, physical findings, discontinuation, dropout, occurrence of any cardiovascular events, and occurrence of any adverse events. At study registration and after 6, 12, 24, and 36 months, laboratory tests and biomarkers were examined. The primary efficacy endpoints were changes in urinary albumin-creatinine ratio, UACR, and plasma BNP levels from baseline. The secondary efficacy endpoints were the changes in other biomarkers in addition to time until occurrence of cardiovascular composite events. For cardiovascular composite events, Kaplan-Meier curves were prepared. We used the logistic regression model to examine the relationship between the levels of biomarkers and occurrence of cardiovascular events. This study screened 1,267 patients from July 29 to April 2011. Finally, the study was started as follows: 615 patients in the ARB group and 613 patients in the non-ARB group. Here are the baseline characteristics. Mean age was 66 years old, and 58% men were included in this study. Blood pressure level and frequency of smoking, dyslipidemia, and diabetes were similar between the two groups. There were no significant differences in the frequency of cardiovascular factors. This is a prescribed antihypertensive drugs of the two groups. In the non-ARB group, calcium channel blockers were prescribed in almost all patients throughout the study. This slide shows the time course changes of blood pressure and pulse rate. There were no differences in the changes of blood pressure and pulse rate between the two groups. This slide shows the changes of UACR and BNP levels. Both baseline UACR and BNP levels were similar in the two study groups. Compared to the baseline, UACR decreased over time in the ARB group more than in the non-ARB group. The difference in the changes in UACR over time between the two groups, the primary endpoint, was statistically significant. The BNP slightly increased over time in the both groups, but the changes of BNP was significantly smaller in the ARP group than in the non-ARB group. Other biomarkers, including urinary 8-OHDG, high molecular adiponectin, and high sensitive CRP, were not different between the two groups. However, serum adiponectin level showed a larger increase, and EGFR showed a larger decrease in the ARB group than in the non-ARB group throughout the study period. The cumulative incidence of cardiovascular events is shown in the figure. Fatal and non-fatal cardiovascular events were fewer in the ARB group, but not significant. The details of fatal and non-fatal composite cardiovascular event is shown in this table. Each event rate was higher in the non-ARB group than in the ARB group, but not significant. Prognostic factors for cardiovascular events were examined. Included factors were gender, age, body mass index, smoking, diabetes, dyslipidemia, EGFR, past history of cardiovascular events, UACR, BNP, adiponectin, hsCRP, and urinary 8-OHDG at baseline. The BNP and UACR at baseline were independently correlated with the occurrence of cardiovascular events after adjustment for other biomarker levels and conventional risk factors. There were differences in adverse events during the study period. However, there were no severe adverse events in both groups. Summary. Attempt CVD is the first study to prospectively examine the long-term effects of ARB versus non-ARB treatment on BNP and USCR in the hypertension patients. The 36-month follow-up was attained in 985, that is 80% of the study period. ARB treatment suppressed an age-associated increase in BNP independently of blood pressure. ARB treatment decreased USCR in the hypertension patients in 3 years. ARB treatment does not significantly prevent fatal and non-fatal cardiovascular events. BNP and USCR at baseline were independently correlated with occurrence of cardiovascular events after adjustment for other biomarker levels and the conventional risk factors. In conclusion, ARB therapy in the case of Attempt CVD study, telmisartan improved USCR and BNP. USCR and BNP were independently correlated with the occurrence of cardiovascular events. We thank all patients, physicians, and medical staff who supported this study. I would like to express my gratitude to the physicians of 168 clinics or hospitals in Japan. This study is published today, European Journal of Preventive Cardiology, online first. Thank you for giving me this opportunity and your kind attention. Thank you.
Thank you very much, Dr. Ogawa. Dr. Thierry Gillebert from Gent will discuss Attempt CVD.
Thank you very much. Mr. Chairman, ladies and gentlemen, dear colleague. Telmisartan is an established antihypertensive drug, and in the on-target, it has been shown that it's statistically not inferior to ramipril with regard to major cardiac outcomes. So it's a good antihypertensive drug, as good as an ACE inhibitor. Some people formulated hypotheses that ARBs would be inferior to ACE inhibitors with regard to total mortality and with regard to myocardial infarction. This has been undermined by the results of OnTarget. This view was recently confirmed by the Cochrane Library Review and by a study published by Tomopoulos in Journal of Hypertension. That's a study from Zanchetti and Parati. It's still debated. So my goal now is to further put the study under scrutiny in a broader perspective. For this reason, I go back to the 2013 guidelines. And these guidelines tell us that all 5 classes of antihypertensive drug all are suitable for initiation and maintenance of antihypertensive treatment. But some drugs are to be preferred in specific conditions. And the guidelines mention ACE inhibitors and ARBs in the presence of microalbuminuria, renal dysfunction, and heart failure. To put the study further in perspective, I illustrate the results of a study in HFpEF subjects, in more than 2,000 HFpEF subjects. The people looked at microalbuminuria, decreased function of the kidney, and the combination of both items on prognosis. If you have none, you are in blue. If you have both, you are in red. And if you have one of the two, you are in the middle. This practically means that decreased renal function and microalbuminuria are independent determinant of prognosis in HFpEF subjects. On this background, we can look at the Attempt CVD, which is a biomarker study. And I have some questions that we could maybe expand on during the discussion. Why would we set up a biomarker study once we have data on hard endpoints? Can we improve treatment by selecting patients on the basis of these biomarkers? And will a subtle change of urinary albumin to creatinine ratio, or BNP, I wrote here, which is unrelated to outcome, but this was not what was shown in the study, so this is an error. I apologize for that. Be considered a therapeutic success or just a surrogate endpoint. I want to give a clarification. At enrollment, patients were stratified for usage of ACE inhibitor, and you had 6% of ACE inhibitor treatment in both arms. Add-on use of an ACE inhibitor was prohibited in the ARP arm, and at the completion of the study, ACE use was almost not existent in the ARP arm and 12.6% in the non-ARP arm. So basically, it's a study of telmisartan versus 90%, or let's say 87% of people with no inhibitors of the renin-angiotensin system. I would go back to HFpEF, and I would go back to the issue that your treatment may decrease renal function. You see on the left the iPreserve study, and you see that both in the treatment arm as in the control arm, you see a progressive decline in renal function. But the decline is more pronounced in the ARP arm. And this impacts on prognosis. On the right, you see that the people with worsening renal function have a worse prognosis in both arms than the people without. This is important, and I asked my colleague to illustrate this worsening renal function in his data set. And that is what he told me. He had another definition of worsening renal function. It was increasing serum creatinine of more than 0.3 or more than 25% at any time during follow-up. So the definition is different than the definition from the iPreserve study. And he had respectively 22 and 17% of his patients having developed worsening renal function, but did, in the study under scrutiny, did not impact on the outcome of the patients. What I mean, because I was not clear, what I mean is that worsening renal function did not impact on outcome, but there was no difference in the outcome in worsening renal function between the ARP and the non-ARP arm. So far, my comments.
Thank you very much, Gillebert. Okay, so first, Dr. Gillebert will ask a question.
Yes, I would like to ask a question. You see that you have, in a way, a small increase of a small changes in BMP, but well in the normal range. And you also have some slight differences in proteinuria, but this is 3 to 4 milligram per gram creatinine in the range of 20 to 30 milligram. This all is not that much, and it's not related to outcome. What's the relevance of this?
Thank you for your comment, especially urinary albumin. We checked aerobie therapy, exactly EGFR slightly decreased, but composite event decreased. So I think urinary albumin, UHCR is more important than creatinine EGFR, and BNP increase very small, but BNP increase very small, but age-related BNP increase suppress this phenomenon is very useful for future event. If we follow up 3 years or 5 years or more longer, this BNP effect is more elucidated and prognosis is related. So ARB therapy, longer follow-up therapy, we found the ARB therapy favorableness.
So mainly what you tell is that if we would follow these patients up for 6 to 10 years,
yes,
that you would see clear difference in outcome.
I think so.
Okay.
Can I ask? Dr. Ogawa, so Attempt CVD is really interesting results of the studies of the biomarkers. So after getting this interesting results of biomarkers, so what studies do you plan to do next?
Thank you for your question. As I told you, this study 1,012 patients and follow-up period 3 years. So, but this BNP and UHCR is a significant prognostic factor. So, as I told you, longer prognosis, the effect of ARB is more clear. So we would like to study more patients and more longer clinical outcome.
Okay, thank you very much, Dr. Ogawa and Dr. Gillebert.
Thank you very much. We are going to move on to the next presentation, and it's now my pleasure to introduce Dr. Bryan Williams, who is going to present the principal results of the prevention and treatment of hypertension with algorithm-based therapy pathway 2, optimal treatment of drug-resistant hypertension. Thank you very much, Bryan.
Colleagues, it's my pleasure to present the results of the Pathway 2 study, optimal treatment of drug-resistant hypertension. On behalf of the executive group, myself, Tom MacDonald, and the chair of that group, Maurice Brown, and all of the pathway investigators who I will show at the end of this presentation. We have no conflicts to declare in relation to the work. This was a British Hypertension Society investigator-initiated and led study funded by the British Heart Foundation and the National Institute for Health Research in the United Kingdom. So by way of background, resistant hypertension has been defined as uncontrolled blood pressure despite treatment with maximal tolerated doses of 3 blood pressure lowering drugs. International guidelines now have reached consensus that the 3 blood pressure lowering medications would normally be an ACE inhibitor or an ARB, plus a calcium channel blocker, plus a thiazide-like diuretic, or A plus C plus D. The prevalence of resistant hypertension is reported to be about 10% of hypertensive patients, and that would equate to 100 million people globally. These patients are at especially high risk of cardiovascular disease and premature death, presumably due to their prolonged exposure to poor blood pressure control and the comorbidities associated with this condition. Remarkably, the optimal drug treatment of resistant hypertension remains undefined. Recent meta-analysis suggests that spironolactone, an aldosterone antagonist, at a mean dose of approximately 25 milligrams a day, is an effective treatment and can lower clinic blood pressure by about 24 over 8 millimeters of mercury and ambulatory blood pressure by 9 over 3. However, the sum total of data comes from 3 small randomized controlled trials with a total exposure to spironolactone of 134 patients and all against placebo, as well as observational and open-label studies that will be regarded as low quality by guideline developers. There have been no randomized controlled trials directly comparing spironolactone with other blood pressure-lowering drugs to determine whether spironolactone is the most effective treatment for resistant hypertension in most people. In addition, the pathogenesis of resistant hypertension is poorly defined. Prior studies have suggested that excessive sodium retention, despite background diuretic therapy, may be responsible for the treatment resistance. Plasma renin levels are inversely related to sodium load and therefore could, at baseline, provide a means of personalizing therapy. Our hypothesis was that resistant hypertension is a sodium-retaining state that is characterized by an inappropriately low plasma renin level despite treatment with A plus C plus D. Further diuretic therapy with spironolactone will be more effective at lowering blood pressure than alternative treatments. And these alternative treatments target different mechanisms. We chose bisoprolol, a beta blocker, beta sympathetic blockade that also suppresses renin production. We chose an alpha blocker, doxazosin modified release, an alpha blocker that is also a vasodilator. And we measured plasma renin because our hypothesis was that patients with a low plasma renin, whilst treated with A plus C plus D, that the level will be inversely related to the response to spironolactone. Excuse me. This is the design of the Pathway 2 study. It's a double-blind, placebo-controlled, randomized crossover study. Patients were screened and were comprehensively evaluated for non-compliance with therapy by using directly observed therapy to show that their blood pressure didn't fall on treatment. We also used home blood pressure measurements to ensure that they did not have white coat hypertension, and they were evaluated by specialists to exclude secondary hypertension. Thereafter, they entered a 4-week single-blind placebo-controlled placebo run-in, and on background treatment with A plus C plus D. And they were then randomized to receive one of 4 treatments: spironolactone, doxazosin MR, placebo, or bisoprolol. Each patient received all of these treatments in a random cycle order. Each treatment cycle was for 12 weeks. There was forced titration from the lower dose to the higher dose at 6 weeks, and there was no washout period between cycles. Home systolic blood pressure was measured at 6 and 12 weeks, and the average of these readings at both time points were used to determine the primary endpoint, which was the average systolic response to these interventions. There's also an amiloride open-label run-out, but we won't be reporting the results of that today. The study has a hierarchical primary endpoint. It's the difference between average home systolic blood pressure, spironolactone versus placebo. If that is positive, we proceed to the next component, the difference between spironolactone and the average of the other 2 drugs. And if that is positive, we proceed to the next component, and that is the difference between spironolactone and each of the 2 active drugs. We also included a number of secondary outcomes: seated clinic blood pressure responses, average control rate with a stringent control of a systolic blood pressure at home less than 135, safety and adverse event reporting, and also the predictive value of plasma renin to predict the best response to treatment. We screened 436 patients. 335 were randomized. 21 had no follow-up with any drug, and therefore 314 comprise the intention to treat analysis. The majority of patients received every drug cycle, and all patients completed, 230 patients completed all cycles. This is the baseline demographic of our population. The mean age was 61 years, about 2/3 were men. The home average blood pressure was 147/84. The clinic blood pressure was 157/90. Renal function was normal. eGFR on average was 91. Patients with an eGFR of less than 45 were excluded. About 14% of patients were diabetic. This is the first component of the primary outcome. Spironolactone was significantly greater than placebo at lowering home systolic blood pressure minus 8.7 millimeters of mercury. We proceeded to the second component. Spironolactone was significantly superior to the average of the response to the other two drugs, minus 4.26 millimeters of mercury systolic. And spironolactone was superior to the individual comparisons with doxazosin and bisoprolol, in each case, highly significant data. This shows the achieved home systolic blood pressure in these patients, and you'll notice that the average achieved pressure on spironolactone was lower than with the other treatments and was less than 135 on average. This is the primary outcome graphically. Baseline, placebo, the response to spironolactone, the line showing the threshold for blood pressure control, and then the response to the other two blood pressure lowering drugs. These are secondary outcomes, looking at the clinic blood pressure response. Again, spironolactone was highly significantly greater in its response to placebo, to the average of the other two active drugs, or each of the active drugs. The typical response to spironolactone, mean change from baseline in clinic systolic blood pressure was minus 20.7 millimeters of mercury. Interestingly, you'll notice that placebo on clinic blood pressure also has a significant response that's not seen on home blood pressure readings. I think this is relevant to discussion about using clinic blood pressure in these patients. We also saw a significant dose response to spironolactone and less so with the other drugs. This suggests that the dose of 50 milligrams of spironolactone at the top of the dose range used here may not be at the top of the dose range for this drug when used for resistant hypertension. When we looked at blood pressure control rates using a very stringent criteria of control on home systolic blood pressure, amazingly almost 60% of these patients with resistant hypertension were controlled to this value on low-dose spironolactone, and this was highly significantly greater than the other treatments. When we look at serious adverse events, we saw no evidence of a signal of significant adverse events associated with any treatment relative to placebo, albeit with only 3 months duration of treatment in this trial. We looked specifically at potassium because of concern that giving spironolactone on top of background RAS blockade might result in an increase in serum potassium that might prompt treatment withdrawal. This is a stack diagram showing the potassium values on each of the drugs, and spironolactone is in blue. And clearly this is shifted to the right at the end of the study compared to the other treatments at their end of study potassium values. You will notice we found that the average change in potassium was about 10% from baseline on spironolactone, baseline level being 4.1 millimoles per liter, increasing to 4.5. However, we excluded patients with significant renal dysfunction, patients less than eGFR of 45. We also looked at the upper end of potassium. Only 6 patients in this trial receiving spironolactone developed a potassium greater than 6 millimoles per liter, typically up to 6.5, and in each case, this was managed by the clinical team without any complications. We then looked at the renin profile in terms of predicting response. You see at the bottom here the frequency distribution for renin, and for those who are familiar with looking at plasma renin levels, these levels are low by and large for patients who are currently treated with A plus C plus D, all of which would be expected to increase baseline plasma renin. So this was consistent with our hypothesis that in a majority of patients with resistant hypertension, this is a low renin state consistent with sodium retention. We also saw a very strong inverse relationship with the response to spironolactone. Those with the lowest plasma renin and therefore the highest sodium load had the greatest response in terms of blood pressure lowering to spironolactone, consistent with the likelihood that this is acting as a diuretic and producing a response in a population of patients who are sodium loaded. In contrast, the response to the other drugs was less dramatic in relation to plasma renin and relatively flat. And you'll notice that the equivalence with the other drugs only begins to occur at the higher levels of plasma renin. In the majority of patients, spironolactone was by far the most effective drug. So in summary, spironolactone at a dose of 25 to 50 milligrams daily is overwhelmingly the most effective drug treatment for resistant hypertension. Spironolactone in this study controlled almost 60% of patients with resistant hypertension to a home systolic average value of less than 135 millimeters of mercury. And it was 3 times as likely to be the patient's best individual drug versus other active treatments such as doxazosin and bisoprolol. Spironolactone was well tolerated, with no significant excess adverse events compared to other treatments in this study, with the caveat that serum potassium levels and renal function should be monitored on treatment, and the treatment duration was almost certainly too short to see the one side effect reported for spironolactone in longer-term studies, that of gynecomastia, which occurs in about 6% of men and responds to treatment withdrawal. In addition, we found that the response to spironolactone was inversely related to plasma renin, and unlike other active treatments, was strongly dose-dependent, supporting the hypothesis that the dominant cause of resistant hypertension is sodium retention, despite background treatment with thiazide diuretic therapy. The implications of these findings are important. Pathway 2 is the first randomized controlled trial to directly compare spironolactone with other active blood pressure-lowering treatments in patients with well-characterized resistant hypertension. The result in favor of spironolactone is unequivocal. Spironolactone is the most effective treatment for resistant hypertension, and these results should influence treatment guidelines globally. And finally, we would now argue that patients should not be defined as resistant hypertension unless their blood pressure remains uncontrolled on 3 drugs and having failed to respond to low-dose spironolactone as well as the current standard of best care. Thank you for your attention. I'd like to acknowledge the patients who participated in the study, the investigators who made it happen, and the funders, British Heart Foundation and the NIHR, and also all of the people who made this study happen as investigators who are listed on this slide.
Thank you very much, and now we welcome Dr. Mancia for discussing this study.
Well, I think Professor Williams and colleagues need to be congratulated. This is a very nice and important study. And I would like to emphasize some of the strengths and the important aspects of these studies for future practice and guidelines. Sorry. Okay. Yes. Well, we can fully agree with Professor Williams that there are very few randomized trials comparing different 4 treatment steps. And to date, the choice of the 4th drug in resistant hypertensive patients is almost entirely empirical. There is, and there was, the widespread perception that anti-aldosterone drugs could be more effective. But this has not been established based on appropriate protocols and high-quality data. And this is what has been achieved in the study Professor Williams presented. Yeah. Which has a number of strengths, elements of strengths. First of all, the design, randomized, double-blind, and masked, adequate statistical power for the difference in blood pressure which was selected. And then there was a placebo group plus comparisons with 3 commonly used drugs in resistant hypertension. And 2 other elements of strength which I would like to emphasize because they are important. That is the crossover design and use of home blood pressure as the endpoint. Crossover design is an extremely demanding design. It's not widely used because it takes just an imbalance of dropout of patients to destroy the study. So it is a little bit risky. But if successful, and in this case it was successful, it can make the between treatment differences much more reliable than in parallel group studies because the comparison is done within individuals. And one other element of strength I would like to emphasize is that the duration of each treatment was 3 months, and this ensures against the possibility of a carryover effect, which is sometimes an element of weakness in crossover studies. And then I like very much the use of home blood pressure because home blood pressure compared to classical, conventional blood pressure for antihypertensive treatment studies has an important value. It is closer to real life, has a greater reproducibility. Prognostic value has been shown in several studies to be better than home blood and office blood pressure. And it appears to have less placebo effect, although I put a query, Bryan, here, because this is not actually what you found in your study, so it's a little bit different from what it has been found before, which is interesting. You've seen the data. They couldn't be more clear. The spironolactone came up as the unquestionable winner by great distance. There were several millimeter of mercury difference, so it's not only statistically significant difference, it's a clinically significant difference. And there was no price to pay because side effects profile was fine and hyperkalemia was clinically irrelevant in a way, although, of course, you were cautious in suggesting that renal function should be monitored anyway. And I couldn't agree more that this will have implications for future practice and for guidelines. I think from now on, the choice of the 4th drug is based on scientific data. And definition of resistant hypertension and guidelines, I believe there is no alternative but to change it. You see from the previous paragraph, from the initial paragraph here, what more or less has been the definition in most guidelines: failure to reach blood pressure targets despite use of 3 drugs, including a thiazide or thiazide-like diuretic at adequate doses. I think now we have to add, it's a different wording, but the concept is the same, that before defining a patient resistant hypertensive, we need to test whether there is a response to an anti-aldosterone agent. So the study is very important, but let me now ask a question. And despite the clarity of the data, despite the superiority of spironolactone, do you think that the mineralocorticoid receptor antagonist should always be the 4th choice drug? Is there room for other drugs, even after pathway 2? And can a treatment approach based on patient pathophysiological phenotypes bring further improvement? And I tell you why I'm saying this, and it's partly based on your own study. First of all, there has been another among the very few available randomized studies in which 2 different treatments were tested, and one of them was successive nephron blockade by different diuretics. And this came out as a winner compared to a renin blockade type of treatment based on a RAS blocker and a beta blocker, as you can see from the greater fall in office and ambulatory blood pressure in the multidiuretic treatment group. So this supports a hypervolemic hypothesis, but through a different approach, not the one based on spironolactone, but one based on multiple diuretic treatment. This is the first thing. Then what do we do when we have a phenotype in which there is a predominant vasoconstriction based on high renin levels or based on sympathetic activation? And we've recently shown that in resistant hypertensive patients, indeed, there is a very marked degree of sympathetic activation. I'm saying that base this on your own study, because if you look at the effect of different treatments, well, spironolactone, as you said, had an inverse relationship with the plasma renin level. That is, when renin was high, the effect was small. And this, from your figures, is 30–40% of the patients. The problem is that the two other drugs that you tested, that is, the drugs acting one against renin and the other one against the sympathetic activity, didn't do any major thing. So where are we left with these 40% of the patients? And what do you have in mind for future studies?
Well, I mean, the first thing to say is that we have a lot of data. So in addition to what we have presented today, one of the nice things about Pathway program is that we incorporated quite a lot of mechanistic studies. So we have done studies looking at bioimpedance. We have done studies looking at hemodynamics in these patients. We've done sodium studies. So there's a lot more data to come in terms of characterizing the kind of patients who responded well to spironolactone. And we need to look and see whether there were cohorts of people who responded particularly well to the other drugs and whether there was a phenotype associated with that. And I think because of the way we've done the study of crossing over in each individual patient, we'll have the physiological correlates which will help us do that. So that would be interesting. I thought your first point, Giuseppe, was really important, and that is, I guess, how much of this is the magic of spironolactone, if you like, and how much of it is actually just that we're giving more diuretic. And because everybody's on a background of a thiazide, I think many of it was argue probably some of this resistance has come about because we're not giving enough diuretic to many hypertensive patients. And what we're doing with spironolactone is giving a diuretic that acts in a different part of the nephron, like the multiple site approach, and that is providing more diuresis and giving us the kick that we need to get blood pressure down. So in other words, would that be replicated by giving more thiazide at much higher dose? Would it be replicated by giving a miloride or giving any other diuretic that acted in a different part of the nephron? And I think that is definitely the next study that we'd like to do as part of the Pathway program. But I think what is important is that when people are looking at different strategies to treat resistant hypertension, if those strategies don't target in some way natriuresis, then it's going to be very difficult to understand how they're going to work based on the kind of data we've got.
Thank you very much for this nice piece of science.
Thank you very much for the presentation of this study, which opens a new window in the treatment of our patients with resistant hypertension.
Okay, next speaker is Dr. Maurice Brown from Cambridge, Great Britain. He will talk about the principal results from prevention and treatment of hypertension with algorithm-based therapy pathway, comparison of single and combination diuretics and essential hypertension pathway 3. So, Dr. Brown.
I can see it to start with. Thank you very much. Thank you very much, and thank you for the opportunity of presenting the results of the next Pathway program trial. The relative famine of small new molecules makes the reappraisal, maybe the repurposing of old drugs, ever more important. However, in the absence of commercial interest, the studies in which they are the target or the tool require academic groups of investigators with external peer-reviewed funding, such as acknowledged here. The Pathway program was established 8 years ago with just such a purpose in mind by the British Hypertension Society. And these are first results from the two studies you're hearing, which we believe will enable potassium-sparing diuretics to leapfrog into prominence for the treatment of hypertension. Since data lock in early July, Professor Williams, Professor MacDonald, and myself have scarcely been able to contain our excitement at the findings, of which this is the first public presentation. Diuretics, despite targeting the only definite cause of hypertension, salt, have slipped in usage. In recent years, they've been tested mainly at suboptimal doses as comparators for branded newer agents. One of the issues has been that because of so-called metabolic problems such as hypokalemia and impaired glucose tolerance, the view came about that low-dose thiazides are maximal, avoiding metabolic consequences without compromising their ability to lower blood pressure. But this view has now been disproven by formal dose response curves. The increased risk of diabetes appears to be linked to potassium depletion and might be avoided, so the hypothesis has gone, by the use of potassium-sparing diuretics, and that is what we had set out to test in Pathway 3. So our hypothesis is that amiloride will have the opposite effect to hydrochlorothiazide on potassium and glucose, but the same effect on blood pressure. That the combination of diuretics acting at different sites in the nephron will be synergistic for sodium loss and hence on blood pressure reduction. And that consequently, the combination of half maximal doses of amiloride and hydrochlorothiazide will neutralize the undesired effects of hydrochlorothiazide on glucose and potassium, but potentiate the desired effect on blood pressure. We enrolled patients with uncontrolled hypertension, with the major difference from the Pathway 2 population that they were not receiving background diuretic. They were required to have at least one further component, other than hypertension itself, of the metabolic syndrome. Around 440 patients were randomized to receive either hydrochlorothiazide in the relatively high doses of 25 to 50 milligrams, amiloride at substantially higher than doses which might be used in practice, and the combination of amiloride and hydrochlorothiazide at half the doses from when they were used on their own. This was a 6-month parallel group study with forced titration of the doses at 12 weeks, 3 months. The primary outcome was the difference from baseline in the 2-hour glucose on an oral glucose tolerance test performed at baseline 3 months and 6 months. And the principal secondary outcome was the difference from baseline in home systolic blood pressure measured at 3 and 6 months. As in Pathway 2, we used a hierarchical primary endpoint. Our thinking was that amiloride on its own would be the best test of the mechanistic hypothesis that raising potassium would prevent glucose tolerance. But because amiloride has never been used on its own in long-term outcome studies, we should look also at its combination with hydrochlorothiazide. So if our first comparison was significant, our second hierarchical primary endpoint was the comparison of 2-hour glucose on glucose tolerance between the combination and hydrochlorothiazide. The key secondary measures included home systolic blood pressure, a number of biochemical parameters, and safety and adverse events. The consort diagram shows that 440 patients were randomized to the 3 treatment arms, that approximately 130 patients in each arm were available for the intention to treat follow-up, and that the main reason for patients dropping out before full per protocol analysis was either adverse events or deviations from the protocol, sometimes those two going together, usually in the form of patients not complying with all measurements of all glucose tolerance tests. The baseline demographics are shown firstly just for amiloride, age in the 60s, 40% female, somewhat obese, a clinic blood pressure of about 155 over 90, home pressure 5 millimeters lower, and then the breakdown of background treatment, small number of previously untreated, 90% on RAS blockade, And then by far and away the major extra criterion of the metabolic syndrome was central obesity. These are the other two groups, no significant differences in the demographics. I point out finally that around a third of each group had impaired glucose tolerance at baseline on their initial glucose tolerance test. So that gives me an excuse before coming to the results just to remind you what the all-glucose tolerance test is. It's the measurement of plasma glucose over 2 hours after the administration of a 75-gram load. And our primary endpoint looks at the 2-hour glucose, which in long-term studies has been the best predictor of the development of diabetes. And the question was, would that 2-hour glucose change over time, and in particular, would it go in opposite directions between the thiazide and amiloride? So the first part of our hierarchical endpoint looks at the single drugs, amiloride versus hydrochlorothiazide. How would the 2-hour glucose separate over time? The result was highly significant. The plasma glucose at 2 hours increases on the thiazide and falls on the amiloride. The first time a potassium-sparing diuretic has been shown to achieve this effect. So since the first part of and here are the numbers for that, around a half millimole per litre difference between the amiloride and the thiazide. And that's the average over 12 and 24 weeks. So since our first hierarchical endpoint was positive, we move to the second. And here again, we see that the plasma glucose has fallen on the combination, being nearer to the value in the amiloride on its own. And that too is significant. That's the average over 12 and 24 weeks. At 24 weeks on its own, the difference is somewhat larger, a difference of 0.7 for amiloride, 0.6 for the combination. So just put all those numbers in one place, you can see that over both time points, all the differences from the thiazide are negative. It's always in favor of a potassium-sparing diuretic, and all are significant. And just for completion, here is the change from baseline. So looking at the 2-hour glucose compared now to the baseline value, and you can see that the values of the potassium-sparing diuretic are going down, whereas they rise on the thiazide. So the interesting question is, how come the value on the combination was so much closer to the amiloride on its own rather than halfway in between, where we were rather worried we wouldn't then have the power to see a difference? Was it being driven by blood pressure? Is blood pressure the main driver of glucose tolerance? So here is the blood pressure data, the main secondary endpoint, home systolic blood pressure over the 2 main visits after baseline. And amiloride at 10 to 20 milligrams is as effective as high-dose hydrochlorothiazide. What about the combination? We used half the dose of each drug in combination. Would it be as effective, as less effective, or could it even be synergistic? The half dose of combination of each drug lowers blood pressure by 3.4 millimeters on average more than each drug used alone. And we think this reflects greater natriuresis when the 2 drugs are used together, the best measure for which is the relative increase in plasma renin. It rose almost 4-fold on the individual drugs. One of the reasons why in pathway 2 we're certain that those renin results are relatively low for the patients. But here you can see it rises almost another 2-fold more in the group of patients receiving combination. So I move now to some other biochemical parameters, of which the first is potassium, plasma potassium over the 6 months of a trial. Not surprisingly, it goes down on the thiazide, up on the amiloride, but we were really relieved at the end of 6 years of doing the study to see we had chosen the doses correctly, and the dose of the amiloride exactly counteracted that of hydrochlorothiazide. The other well-known biochemical effect of thiazide is to increase uric acid. Amiloride, we find, is completely neutral, no risk of hyperuricemia on potassium-sparing diuretic. But in this case, where presumably blood pressure is not playing a role, there's not quite the same protection in addition to the amiloride when added to the thiazide. I return to the glucose tolerance test because area under the curve was a secondary endpoint. And again, you can see the green line for amiloride is drifting down over the course of the study with a significant difference compared to thiazide. But in this case, the combination did not reach statistical significance. And my my penultimate biochemical presentation is for the HbA1c, where there is no difference between the drugs. In fact, this is a very expanded axis. These are 0.1, 0.2 differences, with a significant increase in all three diuretics in the first 3 months. This has been described before for spironolactone, and spironolactone being said to impair glucose tolerance as a result. I think that's not right. I think there's something interesting going on with blood flow distribution causing this change in this rise in HbA1c. So my final biochemical slide is looking at the relationship of glucose at 6 months against potassium. And although this is the first time a significant negative correlation has been demonstrated, actually it seems to disprove changes in potassium being the major influence on glucose, only 2% of the variance being due to changes in plasma potassium. So finally, the safety data, and I'll show it again just for amiloride to start with. These are the absolute number of events and percentages, and then the numbers for combination and hydrochlorothiazide. And the only one which stands out is hyperkalemia, but actually these are small numbers, and even these were just reports by some of the research nurses of values which were just above the laboratory normal range. And if, as we did for pathway 2, we plot the data as a stacked histogram, you can once again see that the expected changes, potassium moving to the left in the thiazide group, staying unchanged in combination in red, and moving to the right in the amiloride group. But here there aren't even any values approaching 6. The highest recorded potassium was 5.8. It simply is not a clinical problem, despite most of these patients being on background RAS blockade. So in summary, amiloride 10 to 20 milligrams had the opposite effects to hydrochlorothiazide at high doses on 2R glucose and potassium, but achieved the same fall in blood pressure. The combination of amiloride with hydrochlorothiazide was neutral for glucose and potassium and reduced blood pressure by 3.4 millimeters, more than twice the dose of each single drug. Amiloride was well tolerated, with no incidence of potassium greater than 5.8. So the implications, we believe, are that the combination of amiloride and hydrochlorothiazide is a win-win if both are used at equipotent doses. The combination amplifies the desirable effects of each drug and cancels out the undesirable changes in blood glucose and potassium. The combination is in fact the only diuretic which has been shown to be superior to active comparators in outcome trials compared to calcium blockade on heart failure in the INSIGHT study and compared to beta blockade against all cardiovascular outcomes in the MRC trial in the elderly. And so we believe we can now conclude from the 2 studies we've presented that potassium-sparing diuretics are effective and safe and can be preferred choices for the treatment of hypertension. Thank you.
Well, thank you very much, Dr. Young. So Dr. Coca from Barcelona will discuss pathway 3.
Thank you very much for inviting me to discuss the Pathway 3 study. It's, in fact, a great honor. In the next 6-7 minutes, I will try to make some comments on different aspects of this study. First is why? Why to perform a study on diuretics? We have been using diuretics for more than 40 years, but we have many uncertainties in the use of diuretics, and at the moment, we don't know, in fact, which is the best strategy to treat patients with hypertension with diuretics. And this fact is due to the complications, the side effects of the thiazide diuretics and the thiazide-like diuretics, increasing and disturbing glucose metabolism, increasing uric acid, and reducing potassium. But on the other side, we have diuretics that preserve the potassium. But you can agree with me that for many years, amiloride is not a common diuretic use in this moment. So, in summary, there are many uncertainties that justifies the investigation on diuretics in 2015. On the other side, we know that low-dose combinations of many drugs are more effective than the higher doses of the individual components because they achieve similar or even more blood pressure reductions, higher blood pressure reductions, and blunting the side effects of the individual components. So, for this reason, I think there is a clear justification to perform this study. Concerning the aim and the design, the study was aimed to compare effects of thiazide, hydrochlorothiazide, and versus amiloride alone or combined with hydrochlorothiazide with a clear endpoint. Primary endpoint, glucose tolerance, abnormalities in the glucose metabolism. And the second endpoint, most important, blood pressure reduction. The study is randomized in three arms, parallel groups, double-blind, and have the strength of being designed by a group of researchers of the British Society of Hypertension and funded by a public institution. So this means that there is no any kind of commercial bias, and this is a real strength of the study. Concerning the patients included in the study, I think it's important to emphasize that not only were included by office blood pressure, patients in control, higher than 140 systolic, but also having a home systolic blood pressure higher than 130. This is a kind of avoid the inclusion of patients with a so-called white coat effect. This treatment was on top of other treatments. The vast majority of patients were already treated, 85%, and only less than 8% were naive patients. And in addition to uncontrolled blood pressure, patients were included if having some kind of risk, higher risk, at least one component of the metabolic signal. And in fact, 99% of them exhibited central obesity. The main results. Some comments on the main result. The main result is clear. The glucose tolerance test rose in patients receiving hydrochlorothiazide, but fell in patients receiving amiloride. And this difference, as already mentioned by Professor Brown, were significant at 12 and 24 weeks. And these results, and this is the main primary endpoint, are absolutely clear. The secondary endpoint, home systolic blood pressure reduction, in fact, was similar, as expected, in patients treated with amiloride in monotherapy in amiloride on top of the treatment or hydrochlorothiazide. But home blood pressure reduction was greater in patients receiving the combination of half doses of hydrochlorothiazide and amiloride. And you can see that the difference was significant and about 3.5 millimeters for systolic. Concerning the potassium effects and the study of the pathophysiology of the disturbances of glucose metabolism induced by diuretics, we see clearly that plasma potassium rose with amiloride, as expected, fell with hydrochlorothiazide, as expected, and was unchanged with the combination. And this is a very important result because it's one more confirmation that half doses of individual components in a combination may blunt the adverse effects having one of the single components. There was, however, a very weak inverse correlation between plasma glucose and potassium, as was shown by Professor Morris. And in fact, no difference were observed in glycated hemoglobin among the three groups, no difference also in insulin levels, and no difference in OMA index. Probably these results are not a strong support on the hypothesis that changes in glucose metabolisms are related with the increases in, with the reduction in potassium induced by the diuretic. I have some minor criticisms to the study. One is concerning the selection, because the accepted cutoff point for normality in home blood pressure systolic is over 135. The authors selected 130, but what facilitates the inclusion of patients. On the other side, the use of the American Diabetes Association criterion to define metabolic syndrome concerning the abdominal perimeter, instead of using the ATP criterion, also facilitated the inclusion of patients. And in fact, all of them, 99%, had abdominal obesity. Probably using the ATP criterion, not all patients would have abdominal obesity. And the third comment is that there was a loss to follow up about 1/3, what is significant. Anyway, this concerns to me does not affect the final result of the study. There are some rising questions concerning this study. The first is, which is the exact role of plasma potassium in glucose disturbances induced by thiazide diuretics after pathway 3? Are there other partners contributing to glucose disturbance induced by thiazide diuretics? If yes, which? The vast majority of patients needed combination therapy, needs in general combination therapy with different antihypertensive drugs to normalize blood pressure. Is it possible to combine this diuretic combination with other antihypertensive drugs in a single pill to improve adherence? Because the number of pills is related with the adherence to antihypertensive treatment. Finally, the implications, I agree that the implications are important. On the basis of pathway 3, the combination of amiloride and hydrochlorothiazide in equipotent doses becomes the preferred choice for diuretic treatment in patients with insulin resistance, such as obese patients or those with fasting plasma glucose. These findings and previous morbidity and mortality trials data for this combination, particularly the INSIGHT and the MRC in the elderly, supports its first-line use in patients requiring diuretic therapy for hypertension alone or in combination with other antihypertensive drugs. Many thanks for your attention.
Thank you, Dr. Coca. Dr. Bryan, could you answer to the one or two questions?
Well, thank you very much for those comments and your positivity. It is certainly true that the answers seem clear-cut on what the message is for practice, but has given us less information on what the mechanism for benefit is. And I think we'd expected to have a yes to the potassium hypothesis, and that's not certain that it's potassium which is driving the glucose. So there's an unknown there. My own hunch is that the driver to glucose intolerance on diuretics has been a blood flow issue, same with beta blockers, and the drugs which deliver less blood to the skeletal muscle where insulin is acting causes impaired glucose tolerance. And the amiloride is in some way redistributing blood in a different way, but that is speculation. Just on a small point, the number of withdrawals, it's patients who didn't have a complete data set from the glucose tolerance tests. Most of those didn't actually withdraw from the studies. So these drugs were well tolerated.
Okay, thank you very much.
Thank you very much. We are a little bit late on the schedule, so I will ask Dr. Williams to come back on the podium for the next presentation, which will be the parameter study, and I will ask both Dr. Williams and the discussant to try to keep on time. Thank you so much.
It's my pleasure to present the principal results of the parameter study on behalf of the co-investigators of this investigator-led study funded by Novartis Pharma. It's my declaration of interest. Systolic hypertension and an increase in pulse pressure are indicative of arterial aging and large artery stiffening. They're also predictive of incident cardiovascular disease and heart failure, especially elevations in nocturnal blood pressure. Large artery stiffening increases central aortic systolic pressure, or CASP, and central aortic pulse pressure relative to brachial pressure, which increases left ventricular loading conditions. And this abnormal ventricular vascular coupling with aging contributes to the development of heart failure. The purpose of the parameter study was to assess both the short and long-term effects at 12 and 52 weeks of LCZ 696, an angiotensin neprilysin inhibitor, compared to olmesartan, an angiotensin receptor blocker, on measures of central aortic hemodynamics and arterial stiffness in older patients with systolic hypertension and an increased pulse pressure. By way of background, the LCZ 696 is the first in class of an angiotensin receptor neprilysin inhibitor, or ARNI. The molecular entity comprises valsartan and sacubitril. This is the neprilysin inhibitor. The action of valsartan will be familiar to many of you. By blocking the angiotensin receptor, it lowers blood pressure, promotes sodium excretion, promotes vasodilatation, and has favorable effects on vascular and ventricular structure. Blockade of neprilysin potentiates the action of natriuretic peptides, and these have opposing effects to the renin-angiotensin system, and therefore are potentially complementary to the benefits seen with blockade of the renin-angiotensin system. And certainly studies thus far in heart failure with this agent have shown great promise in reducing cardiovascular morbidity and mortality. The parameter study was a 52-week study to evaluate the safety and efficacy of LCZ 696 on central aortic pressure and arterial stiffness in elderly hypertensive patients who, after a washout of their usual therapy over 2 to 4 weeks, were randomized to LCZ 696, 200 milligrams daily as once daily dose for 4 weeks, increasing to 400 milligrams daily for the rest of the study. Or olmesartan, an angiotensin receptor blocker, at 20 milligrams daily, increasing to the maximum dose of this drug, 40 milligrams daily, also after 4 weeks. The primary outcome was determined at 12 weeks when we measured aortic hemodynamics non-invasively. And then there was a follow-up period for a further 40 weeks, during which patients could receive add-on therapy, initially with amlodipine and then hydrochlorothiazide, to achieve optimal blood pressure control, defined as a clinic blood pressure below 140/90. Our population was 454 patients aged at least 60 years with a systolic blood pressure greater than 150 in the clinic and a wide pulse pressure at least 60 millimeters of mercury. Our hypothesis was that in these older patients with stiff arteries and an increased pulse pressure, LCZ 696 will reduce central aortic systolic and pulse pressure more effectively than the angiotensin receptor blockade. And the primary endpoint was to demonstrate the superiority of LCZ 696, 400 milligrams daily, compared with olmesartan, 40 milligrams daily, in reducing central aortic systolic pressure after 12 weeks of treatment. There were a number of secondary endpoints. A key secondary endpoint was the effect of LCZ 696 versus olmesartan at 12 weeks on central pulse pressure, and further endpoints included changes at 52 weeks on both central and brachial pulse pressure, as well as pulse wave velocity, and 24-hour ambulatory brachial and central blood pressure. We used a single method to assess central pressures non-invasively and also pulse wave velocity, the SphygmoCor XL device. We also used 24-hour blood pressure device that was able to measure both brachial and non-invasive assessment of 24-hour ambulatory central pressure, the mobilogram. And all of this data was collected and transmitted electronically, blinded to a central lab for quality control. The study was conducted in 48 sites across 12 countries, representing many regions of the world. We randomized 454 patients, 229 to LCZ 696, 225 to olmesartan. There were few discontinuations throughout the trial. At 12 weeks, 89% of patients were available for evaluation, and 52 weeks, 80%, and this was similar in both arms of the study. Baseline demographics revealed that approximately half the patients were male and about 2/3 were Caucasian, the rest being of Black American or Asian origin. The mean age was 68 years. The estimated GFR was around 80. NT-proBNP at baseline was elevated in these patients, illustrating the degree of left ventricular wall stress at 93 picograms per mil. About 1/3 of the patients were diabetic. Almost all had a prior history of hypertension. Duration of hypertension was 11 years. These are the baseline central hemodynamic and brachial blood pressure data. They all had an elevated central aortic systolic pressure at 144, and the central diastolic pressure was 89. Central pulse pressure was also elevated at 55, and they had evidence of arterial stiffness with an increase in pulse wave velocity at 10 meters per second with a wide range from 8.8 to 11.4. Brachial blood pressure variables revealed significant hypertension in the clinic with a mean systolic pressure seated at 158 and a diastolic of 87, with a pulse pressure above the threshold of 60 for inclusion, averaging around 70. This was the primary outcome of this study, looking at the change in the central aortic systolic pressure from baseline to 12 weeks, comparing LCZ 696 with olmesartan. It was clear and significant that the LCZ 696 produced a greater reduction in central systolic pressure in patients with stiff arteries and isolated systolic hypertension. When we did the per protocol analysis, we saw an identical result, if anything, a slightly greater difference between both treatments, a typical difference about 4 millimeters of mercury in central systolic pressure. When we look at central pulse pressure on the right, again we see about a 50% greater reduction in central pulse pressure in patients treated with LCZ 696 after 12 weeks of treatment compared to the angiotensin receptor blocker olmesartan. If we look at changes at brachial systolic pressure, these are seated measurements, conventional blood pressure measurement in the clinic, we see a greater reduction in seated brachial blood pressure after 12 weeks with LCZ 696 at minus 13.7 millimeters of mercury compared to minus 9.9 with the high-dose olmesartan, and the same differential in pulse pressure with a greater reduction in seated pulse pressure with the LCZ 696. We also undertook 24-hour blood pressure monitoring with the unique feature in this study of being able to also compute 24-hour central systolic pressure. At the top, we're looking at the circadian variation in blood pressure in blue with olmesartan measured over the brachial artery, and in orange with LCZ. At the top of the panel here, you can see that the systolic blood pressure over 24 hours was significantly reduced by LCZ 696 compared to olmesartan. Interestingly, the majority of the difference occurring due to greater nighttime blood pressure lowering with the LCZ 696, the first time we've seen this with an antihypertensive drug and a drug taken once daily. We also saw similar profile of blood pressure changes on central systolic pressure with a highly significant difference and lowering of central systolic pressure over 24 hours with LCZ 696, with the predominant effect occurring on nocturnal pressure. We also looked at changes in NT-proBNP. This is the precursor for BNP that is released in response to wall stress in the ventricle, and in this study was used as a marker of ventricular vascular coupling in patients with stiff arteries. We saw a greater reduction in NT-proBNP from a high baseline of 93 in patients treated with LCZ compared to patients treated with olmesartan, where we also saw a reduction in the release of NT-proBNP. This suggests a more favorable effect on ventricular vascular coupling. And consistent with the mechanism of action to potentiate natriuretic peptides, we saw a highly significant increase in urinary cyclic GMP with the LCZ696 alone, consistent with its mechanism of action. At 52 weeks, the blood pressures, both central and brachial, had come together, and that is because, of course, after 12 weeks, additional therapy was allowed throughout the study. We saw that by the end of 52 weeks and the equalization of blood pressures in this study, more add-on therapy was required for patients treated with olmesartan, 45% receiving additional amlodipine to achieve lower blood pressures compared to 31% with LCZ696, and 18% receiving add-on hydrochlorothiazide compared to 8%. At the end of the study, 68% of patients were still receiving monotherapy with LCZ696 compared to 53% with olmesartan. We also examined pulse wave velocity. This was lowered by both treatments, predominantly as a function of lowering blood pressure, although there was a trend to a greater lowering of pulse wave velocity with the LCZ696. This did not reach significance at 12 weeks or 52 weeks. In an exploratory analysis, we were interested in looking at patients at the upper quartile of aortic stiffness to see whether we could see any further differentiation. And again, although there's a trend to a greater reduction in aortic stiffness in patients treated with LCZ696 at 12 and 52 weeks, despite the fact that blood pressure had become more equivalent at 52 weeks, this did not reach statistical significance. Both treatments were very well tolerated, and there were no safety concerns or indeed any difference in key safety parameters between both treatments throughout the trial. In summary, in older patients with systolic hypertension and an increased pulse pressure indicative of arterial stiffening, the parameter study met its primary and key secondary objectives by demonstrating superior efficacy of LCZ696 400 milligrams once a day compared to olmesartan 40 milligrams once a day in lowering both central aortic systolic pressure and central pulse pressure after 12 weeks of monotherapy. LCZ696 also lowered 24-hour ambulatory systolic pressure and 24-hour late ambulatory central systolic pressure more effectively than olmesartan after 12 weeks of monotherapy, with a more significant blood pressure reduction observed during the nighttime period. There was no difference between the two regimens in central and brachial systolic pressure profiles at week 52 due to the allowance of add-on antihypertensive therapy. However, a higher percentage of patients in the olmesartan group required amlodipine or hydrochlorothiazide add-on treatment. There was no significant difference in a secondary endpoint of carotid femoral pulse wave velocity between the both treatment regimens at week 12 and 52, but in our ad hoc analysis in those with the stiffest arteries, there was a trend towards a greater reduction in pulse wave velocity with the LCZ696, consistent with our hypothesis of de-stiffening of the arterial system with this treatment. LCZ696 was well tolerated in this 52-week study. Adverse events were similar between LCZ696 and the olmesartan treatment regimens. In conclusion, the parameter study is the first randomized study demonstrating the ability of LCZ696 to reduce central systolic blood pressure and pulse pressure more effectively than an angiotensin receptor blocker in high-risk older patients with systolic hypertension and increased pulse pressure. These results suggest that LCZ696 provides beneficial effects on central aortic hemodynamics and function that could provide a therapeutic advantage beyond those observed with conventional RAS blockade alone. Thank you very much for your attention, and thank you to the investigators who made this study happen.
Thank you, Dr. Williams. We are asking now Dr. Packer to come and discuss this study.
I would like to thank the organizers very much for inviting me, but for the last hour I have been wondering why I'm here. Because when it comes to conflict of interest, I am the most conflicted person in this room. Since I was one of the principal investigators of the Paradigm trial that studied LCZ 696, received consulting fees from Novartis, which manufactures LCZ 696, and it's worse than that. I have some personal disclosures to tell you about. I've spent my entire life in the area of heart failure. I know nothing about hypertension. So did the ESC ask me to comment by mistake? Maybe the ESC thinks I know something about LCZ 696, but why talk about the parameter trial? It's a trial in hypertension. I don't know anything about hypertension. So maybe the ESC really actually wants a heart failure investigator to explain how he thinks about blood pressure. Now that would be interesting. After all, heart failure physicians lost faith in blood pressure as a surrogate marker for success more than 30 years ago. Physicians who treat patients with heart failure do not try to achieve a reduction in blood pressure. They prescribe treatments to reduce morbidity and mortality. Physicians who treat patients with hypertension also shouldn't target patients for treatment of blood pressure. They should really prescribe treatments to reduce morbidity and mortality. So did the parameter trial examine the effects of treatment on morbidity and mortality? And the answer, no. What did it find? A 3 to 4 millimeter greater decrease in central aortic pressure, brachial systolic aortic pressure with LCZ 696 ecubitril valsartan compared with olmesartan. Neprilysin inhibition produced a further 3 to 4 millimeter greater decrease in blood pressure. And you may say, so what? Who cares? I know how you're feeling, but this 3 to 4 millimeter of mercury difference seems oddly familiar. Many of you may remember a class of drugs known as alpha-adrenergic antagonists. These were neurohormonal inhibitors, so according to conventional wisdom, they should have done great things for cardiovascular risk. What they did do was lower blood pressure by about 3 or 4 millimeters of mercury when used in monotherapy in placebo-controlled trials. Now, was that a good thing to do? Well, in the ALLHAT trial, one of the largest outcome trials in hypertension, the alpha blocker doxazosin actually increased the risk of major cardiovascular events, especially the risk of heart failure, especially heart failure with a preserved ejection fraction. And in the VHEF trial carried out nearly 30 years ago, the alpha blocker prazosin lowered blood pressure versus placebo by about 3 to 4 millimeters of mercury. And it did not influence the risk of death or the risk of hospitalization for heart failure. So why did the reduction in blood pressure with alpha blockers lead to no clinically meaningful benefit in these trials? Well, as far as I can tell, doxazosin had little effect on central aortic hemodynamics, arterial stiffness, or pulse wave velocity in patients with hypertension. Interesting, it's one of the few drugs that lowers blood pressure but did not reduce ventricular wall stress, at least as measured as N-terminal pro-BNP. Now, is that why the drug didn't prevent heart failure with a preserved ejection fraction? Is that why prazosin didn't reduce cardiovascular risk in patients with heart failure and a reduced ejection fraction? Well, if that's true, then the results of parameter start to get really interesting. In this trial, when compared to an angiotensin receptor blocker alone, the addition of a neprilysin inhibitor to an angiotensin receptor blocker lowered systolic blood pressure by about 3 or 4 millimerners of mercury. But interestingly, it also improved central aortic hemodynamics, and it reduced N-terminal pro-BNP. Well, that sounds familiar. Many of you may remember the results of the Paradigm trial, which I presented at the ESC to the day exactly 1 year ago. And in this trial, sacubitril/valsartan was compared with full doses of the ACE inhibitor enalapril in patients with heart failure and a reduced ejection fraction. In that trial, when compared with enalapril, angiotensin receptor neprilysin inhibition lowered systolic blood pressure by 3 to 4 millimeters of mercury, and it exerted a substantial additional effect to lower N-terminal pro-BNP. But most importantly, the combination of sacubitril/valsartan doubled the effect of enalapril on the risk of cardiovascular death with a very persuasive p-value. So the Paramount trial compared sacubitril/valsartan with valsartan alone in patients with heart failure and a preserved ejection fraction, which you just saw was a reduced ejection fraction. And guess what? When compared with the angiotensin receptor blocker alone, sacubitril/valsartan lowered systolic blood pressure by, yes, 3 to 4 millimeters of mercury, and it lowered N-terminal pro-BNP compared to valsartan alone. Now, that's why the results of the Parameter trial are so interesting. You see, aortic impedance is actually one of the major determinants of structural and functional changes in the heart in patients with heart failure and a preserved ejection fraction. If treatment with sacubitril/valsartan favorably affects aortic impedance, we might expect it to have effects on morbidity and mortality in patients with preserved heart failure and a preserved ejection fraction, just as the drug did in patients with heart failure and a reduced ejection fraction. That is what the ongoing Paragon trial is all about. So this brings us back to the beginning. What does a heart failure investigator think of a reduction in blood pressure? Well, in my opinion, the fact that the drug reduces brachial systolic blood pressure by an additional 3 to 4 millimeters of mercury means nothing. The real question is, how does it achieve the effect? What we've learned from the totality experience with sacubitril/valsartan is that there's something very special about neprilysin inhibition. And we may soon find out that this benefit is seen not only in patients with heart failure and a reduced ejection fraction. Thank you very much.
Well, Bryan, would you like to answer the question raised by Dr. Pecker? We are very grateful from the ESC, despite all the concerns regarding your conflict of interest, you accepted to come and discuss this study. Very short answer, please, Bryan.
Yeah, I think that the situations are very different when you're looking at the impact of pressure changes in patients with heart failure or patients with stiff arteries and systolic hypertension. People with isolated systolic hypertension, we've seen from many trials, have the most spectacular benefits from blood pressure reduction across any population of patients. They get big reductions in stroke, big reductions in hospitalized heart failure, and big reductions in ischemic events. So I think the kind of difference we've seen in blood pressure here would translate into or most likely translate into a significant benefit in this population of patients who are difficult to treat. I think what this study was trying to tease out, whether or not we're having an effect beyond simply blood pressure lowering, because that would be relevant to your hypothesis around heart failure. And I think the observation that we've had a favorable effect on central hemodynamics, we didn't know we were going to see that. And also we've seen the big reduction in NT-proBNP in this population who haven't got heart failure, but they've got certainly wall stress related to stiff arteries, is very encouraging in the sense that we're seeing it across the spectrum of patients, and it does suggest this drug is doing something different to simply lowering blood pressure or simply blocking the renin-angiotensin system, and probably is having an effect to improve coupling of the ventricle, in which case I agree with you. I would predict that if any drug has a chance in diastolic heart failure, which in my view is predominantly a disease of hypertensive heart disease and stiff aorta, then this drug will have a chance.
I completely agree.
Excellent. So
from a heart failure investigator's point of view, I understand that treating hypertension is important to reduce stroke and myocardial infarction, but it's really important for reducing heart failure. And it's particularly important for reducing heart failure with a preserved ejection fraction. And so if you have a drug that does that and lowers N-terminal proBNP, it's something worth talking about.
Excellent. So this closes this hotline session on hypertension. And I'm very grateful to all the speakers and to the audience for their participation in this hotline session. Thank you very much.
Unchain my heart, baby, let me be. 'Cause you don't care. Well, please.
Start with the first guideline that is related to pericardial diseases, and the chairs were Yehuda Adler.
Welcome to Meet the Legend.
Greatly honored and delighted to
Now.
Now.
Now. Now. Right now.
Really right now.
Tune into ESC TV.
Now. For you. All what you need.
my heart.